Hello, I'm James Wallace. I'm an emergency medicine consultant and I'm the Trust Resus and DNA CPR lead. I'm here to give you the talk on resuscitation, a little bit of tips and tricks about the team, who we are, what we do, what training, and a little bit of an introduction to the stuff that we've got in the Trust. So the idea today is to talk through the policies, procedures, training, emergency equipment, and then a little bit about relevant information. You should see on the screen, we've got quite a large team. There's myself, Mark Hampson, the head of Resus and Sim. We've got quite an established simulation team over in Holton, and we're developing a site over here as well. We've got quite a few Resus officers who are now called clinical educators. We've got the assistants, which the name you need to remember is Lisa McKenna, who's the person you contact for all information. So, Resus policies and procedures. Obviously, I'm not expecting you to read every single one in detail, but there are some key nuggets you will need to know, especially around DNA CPR. Training and what we call SEMA, Summoning Emergency Medical Assistance, and the equipment, and a little bit about the audit. These are numbers. If you've got Induction app or through Switchboard, these are key ones to ring. They're not available all the time, obviously, if we're doing training, but if you email Lisa McKenna about any courses, she'll be able to answer. I'm sure you've all seen this. This is the Lilac form, or the Unified Do Not Attempt CPR form. This trust is slightly different to other trusts in that we would like only ST3 pluses to initiate the form. That doesn't mean that anyone else can't start the discussion with the patient and their family, but the first box for completion is by an ST3 plus of any specialty, and ideally we'd like this to be verified by a specialty associate or a consultant within 48 hours. It used to be 24 hours, but obviously working weekends and bank holidays, sometimes it takes a bit longer to get a consultant signature. One thing that we do ask is, if you are going to initiate this form, is to talk with the patient, make an assessment of their mental capacity, document that as best you can, either in the notes or on a mental capacity assessment form, which I'm sure you'll get shown later on. The biggest change that we've done recently is talking to the family. Please, could you, at the earliest opportunity, discuss with the family or a named responsible person for that person, or an independent medical health advocate, an IMCA. There has been some legislation around this, and it is really important that we do communicate decisions with the family. SEMA, Summoning Emergency Medical Assistance. As in most trusts, all the twos is how you get assistance. Where we are slightly different is that for cardiac arrest there's adults or paediatrics, and again you say where you want them to come to. There is an emergency bleep. Obviously you can fast bleep all members of teams that have bleeps, but there is also a slight change in the MET, the medical emergency team, which you may get taught on another date. We have a medical MET and a surgical MET. So a medical MET is an F1 and some acute care nurses, and then if there's another call within a period of time, then there's a second MET call where the medical registrar will get called. The same for the surgical team as well. If a patient collapses outside of the main hospital, so not within a corridor or a building, obviously speak to switchboard, but you also, the switch will probably ask for an ambulance. That is because if a patient isn't within the building area, transporting that patient into essentially A&E can pose a risk to yourselves and the patient, so we do ask the trained professionals to come and attend. If, however, the patient is able to get up themselves, or you're able to assist them into the building for further review, that again is absolutely fine, but do make sure that you are handing over or documenting appropriately if they are a patient. So, the cardiac arrest team meeting. This handover room, which we used to call it the GP assessment unit, is now called the CAU, or combined assessment unit, which is a combination of an acute medical ambulatory unit and a surgical assessment unit. There's a room called the medical handover room where twice a day, 9 AM and 9 PM, it's a full shift handover of the medical team, and 8 and 8 the surgical team do it in another area. 5 PM there's also the evening handover, which I'm sure those rotating into acute medicine will be explained about by the medical team. In this, where it's relevant to cardiac arrest, is there was a sign-in form for members of the cardiac arrest team. Now, the cardiac arrest team in this trust consists of the medical team, so the medical registrar, the acute care nurses, an ODP, ideally the anaesthetic SHO or the first on call, and then some other associated members depending on the time of day, such as the resuscitation officers. The reason why it's important to introduce yourselves at these times is because it is better to introduce yourselves and know what skills you have and what roles you'll play in the cardiac arrest at that point in the cold light of day or evening, rather than by the side of a bed of a patient that you've never met before in a ward you've never been to before. We are also working on what's called silos of working, or silos of care, where within the cardiac arrest, different people have different roles. Someone will be responsible for airway, another person will be responsible for CPR, and then there'll be someone responsible for the algorithm and the defibrillator. And I'm sure that they'll be explained in your resuscitation training. There are other auxiliary members of the team that bring auxiliary pieces of equipment. The Resuscitation Council UK has 2 guidelines for when equipment should arrive, within 30 seconds and 5 minutes. 30 seconds is the immediate airway interventions, and 5 minutes is the full resus kit. We aim, by distributing our resus trolleys, and they are in every clinical area, to have the associated equipment such as intraosseous access and end-tidal CO2 monitoring coming with the ODP. We are looking at installing carbon dioxide monitoring on as many defibrillators as we can across the trust, hopefully in the next few months. But if you want those pieces of equipment, the ODP brings the end-tidal CO2 and the intraosseous access. Each ward has got a defibrillator with a resus trolley, and those resus trolleys will either have an automatic external defibrillator if it's a less acute ward, or a full defibrillator, sometimes with pacing. I'll explain that in a second. Resus training, and I'm sure you'll all be aware in your individual trainee groups of different levels, you have to have different things at different levels of your training. Essentially, if you work in A&E, anaesthetics, acute medicine, an F1 or F2, or a GP trainee, you need advanced life support training. All other doctors, apart from paediatricians of course, need in-hospital life support and SEMA, the Summoning Emergency Medicine Medical Assistant. In addition, all doctors in paediatrics, anaesthetics and A&E or emergency medicine need advanced paediatric life support training, which we do in-house. All doctors that may look after neonates need neonatal life support training. Resuscitation training. We actually offer a wide range of courses here. We have advanced life support courses, both the 2-day and 1-day. We also are a European Paediatric Advanced Life Support Centre, that's a 2-day course. And we also started this year the generic instructor course. So if you've been nominated on your instructor exams, and these are Resus Council UK exams, so ALS, NLS, EPLS, then you could potentially apply. Again, as I mentioned earlier, if you contact Lisa McKenna or by email and ask for availability. So onto the defibrillators. We have one type of defibrillator, the LifePak across the trust. LifePak E and LifePak P. P stands for pacing. Made by Physiocontrol, they're biphasic, so the shock travels between the pads, and they actually all are automatic defibrillators until you open the front door, which we'll show you in training. Transthoracic pacing, and they also can have internal for theatres and or A&E. And they do cardioversion. I'm sure you've all used them before. The difference with our machines is if you want to do subsequent shock, you do need to increase the energy, which is done on the right hand side. And if you're not sure, please come and find us and we'll be able to show you. The shocks are at 200, 300 and then 360 joules. In some areas where we don't have patients, such as corporate or offices or admin, we'll have an automatic external defibrillator. Now these AEDs, again, are biphasic with the same pads. They actually can be put into a manual mode, and they do, as you can see on the picture, have a 3-lead monitoring capability. So whilst they're not pacers, you are actually able to look at the rhythm underlying with the patient. Resuscitation equipment, I mentioned resuscitation trolleys. They're the big red trolleys, you can't miss them. They are fairly standard layouts. You have to open the bottom tray to access them, and then the drawers are all labelled. Second tier resus equipment, as I've mentioned, there's the end-tidal carbon dioxide monitoring and the intraosseous access, but there is also some second tier equipment or medication. In each big red trolley, there should be a blue box with your usual cardiac arrest drugs, adrenaline, atropine, amiodarone. The additional box, which is a big black box, which is a lot bigger, has additional medications such as verapamil, calcium, and all the other medications you may need for a supplementary arrest or additional care. For paediatrics, in the paediatric areas, they have a specific paediatric trolley. There are some areas in the trust we know where paediatric patients and adult patients mix, and in that case, there's a paediatric bag which supplements the adult Resus trolley. The Resus trolleys are checked daily. We have a piece of IT software that allows us to check remotely and actually every single piece of equipment, so you can be fairly assured that the trolleys are checked on a very regular basis. And for a picture, in case you didn't know what a big red trolley looks like, there you go. One thing you can see behind for the paediatric A&E or anaesthetic colleagues amongst us is a weight-based chart. So what we have done is we've taken the Advanced Paediatric Life Support Guidelines and we've calculated them and put them into weight brackets. What we would advise is you use these for the first 2 doses of drugs in cardiac arrest, and for anything after that, you adopt the Northwest Transfer Team, so the NEWTS team, which you can access through our intranet or by going on your phone. And there's more examples. And there's a trolley. As you open the bottom drawer, the drawers all slide out and things are labelled on the outside. And I mentioned the second tier equipment box. And this is the equipment that's on top, things that need to be done in the first 30 seconds, airway, suction, and additional adjuncts. Obviously, there are changes to resuscitation in COVID-19. We've adopted the Resus Council UK's method of that you do not start any form of CPR until you're wearing level 3 PPE. Level 3 PPE being, at the very least, long sleeve gloves, a long apron, visor or shield, and an FFP3 standard respirator. The algorithms are available on the Trust intranet and the Resus Council UK site. Other than that, there is no real change to the resuscitation of adults or children. For more information, please contact one of us by email or phone. I'm sure that guidance may change in the next 6 months, but just be aware that we don't want you to start doing airway procedures on patients in cardiac arrest, because that will put yourself at risk. There are some resuscitation boxes around the trust, usually at the entrances, which contain a grab bag, some high-vis jackets if you're going outside, and some oxygen. The code is super secret and it's 12345. However, in an adrenaline-filled emergency, you may not be able to remember that, in which case when you speak to Switch, they'll be able to tell you the code for the cupboard. And these are checked on a regular basis as well. And here's the paediatric resus equipment, which is a bag with paediatric adjustments in various areas where they're across patients. So in summary, we've covered the policies, the DNA CPR policy, training, what we have available and what you need to do, the emergency equipment, where to find it on every single ward, and important information. If you do have any questions, please feel free to contact us. You are welcome to come to the committee meetings as well. They are every 3 months. But also, if you have any immediate issues, 222 is for the cardiac arrest team, and it's also the same for the medical emergency team.